We'll start with pain, sleep, and temperature regulation, and we'll get into some sensory later on. Pain is very complex, comprised of a pretty dynamic interplay between physical, cognitive, spiritual, emotional, coping mechanisms, environmental factors, and it involves pretty much the whole system. Unfortunately, it's also very subjective. That's one of the problems that we had, and especially when we made it the fifth vital sign, opioid problem, and where we're at right now. We do know that pharmaceutical companies also went to the doctors and said, hey, these pain meds, there's absolutely no way that people will get addicted, put them out like candy. And we obviously know that is very false now. There are a couple of different theories related to how pain is transmitted. But again, we don't know for sure. So we're going to go into a couple of these pain theories later on. First, with pain pathophysiology. There's basically two types of peripheral pain fibers, and they transmit to the spinal cord. They're called A delta fibers and C fibers. We have two pathways that transmit from the spinal cord to the supraspinal areas. That pathway is from the lamina into the dorsal horn of the spinal cord to the hypothalamus and then to the somatosensory cortex. The effective pathway, then dorsal horn, spinal cord, hypothalamus, amygdala, and cingulate area. Those are the basic two pathways. There are afferent pathways. We have efferent pathways, and then we have an interpretation center. When we're talking about afferent pathways, that's what begins in the peripheral nervous system, travels the spinal gate, and goes into the central nervous system. Here is kind of a picture of that pain process. So we're talking about delta fibers, fast, sharp electrical impulses, C fibers, more on that dull, achy, burning sensations, and poorly localized. Often constant too. When we talk about chronic pain, it's usually C fibers. So we basically have three portions of the nervous system that are responsible for the sensation and perception of pain. We have that afferent pathway, which begins in the peripheral nervous system, travels to the spinal gate of the dorsal horn, and then ascends into the higher centers of the nervous system. We have the interpretive center, which is within the brainstem, midbrain, diencephalon, and cerebral cortex. Then have the efferent pathway that then takes the information back down. So that's descending from the CNS back to the dorsal horn of the spinal cord. The process of potentially harmful, which is known as noxious stimuli through the normal functioning nervous system, is called nociception. So then once the tissue is damaged by the exposure to either chemical, mechanical, thermal, noxious stimuli, this causes activation of the nociceptors. We then get four phases: transduction, transmission, perception, and modulation. So pain transduction begins when the tissue is damaged by the exposure at the nociceptor receptors. They're free nerve endings in the afferent peripheral nervous system. They selectively respond to different types of stimuli, and they are located throughout the body, but they are not necessarily evenly distributed. So after pain transduction, we then go to pain transmission, and that is the conduction of the pain impulses along the fibers into the dorsal horn of that spinal cord. So we have that painful stimulus. Now we're going into the dorsal horn here. Both of your nociceptors, so your responses are going in with that. So they form a synapse in those interneurons in the substantia gelatinous and cross the midline of the spinal cord. Then ascend to thalamus, and that's the major relay station of that sensory information. Brainstem, cerebral cortex can get there through multiple pathways, but as you can see here, just to get the gist of the pain perception pathway, this is what we look at. Then it gets to the lateral spinothalamic tract, and that's where we get to more processing. There's that cingulate cortex, there's that limbic system, and the somatosensory cortex. So that's what we're talking about here. So activation of those nociceptors then causes ion channels such as sodium, calcium to open. That creates electrical impulses that travel through two primary types of the nociceptors, which we talked about, the A delta and the C fibers. The delta fibers rapidly transmit sharp, well-localized, fast sensations. So remember that the delta is the fast. The C fibers are unmyelinated and they transmit dull, achy, burning sensations that are poorly localized. So those are the major, the two differences with that. So then we have pain perception, which is the conscious awareness of pain. Occurs in the brain and the reticular system, as well as the limbic systems and the cerebral cortex. So everything that's listed up here helps with that perception of pain. Interpretation of pain is influenced by many factors, including cultural preferences, male and female roles, life experience, past pain experiences. So are you one of those people that they say, oh, I have a high tolerance for pain? So all of that plays in with how your brain is going to interpret and perceive the pain that is coming in. So those three systems interact to produce the perception of the pain. This is called the sensory discriminative system, and that is mediated by the somatosensory cortex, responsible for identifying what is the character, the location, and the intensity of the pain. So then it's mediated through the reticular formation system, the limbic system, and the brainstem. And we call that the cognitive evaluative system, which basically is the individual's learned behavior and therefore can modulate that perception of pain. So the last step is pain modulation. So that is many different mechanisms that increase or decrease the transmission of that pain throughout the nervous system. Depending on what mechanism it is, modulation can occur during or after the pain is perceived. So that is the basic steps: transduction, transmission, perception, and modulation. So when we talk about then the modulators, those are what are found in the pathways, and that mediates information about the painful stimuli. So in the nervous system, we're talking about prostaglandins, bradykinin, lymphokines, substance P, histamine, glutamate. You can see these listed down here. So those can increase or decrease the modulation of the pain. Some of the substances that sensitize the nociceptors in the peripheral nervous system, that is called peripheral sensitization. If it's in the CNS, then it's called central sensitization. That leads to an increased responsiveness and reduced threshold of those nociceptors to cause them to fire with increased frequency, resulting in what is called hyperalgesia, basically a increased sensitivity to pain, so a heightened response to painful stimuli. So you can get a buildup of repeated stimulation of those neurons in the dorsal horn, and that is called the wind-up. And then that can actually result in pathological changes in the CNS, central pain sensitization, prolonged pain, increased sensitivity to future pain. So that's how our past experiences can change our future pain modulation. Glycine, serotonin, norepi, and endogenous opioids, which would be your enkephalins and endorphins, inhibit central nerves so that they can decrease that response. Of note, the endogenous opioids are a family of morphine-like neuropeptides, and they block transmission of pain impulses in the spinal cord, brain, and medulla. So we do have different pain sensations, so we'll go through these so that you understand it. Central pain is from a lesion in the CNS that usually involves the spinothalamic cortical pathways, which we just talked about. Constant burning, electrical quality, and that it's exacerbated by changes in the weather. You'll have that hyperesthesia, hyperpathia, or allodynia are usually present. It's very highly resistant to treatment. So when we think central pain syndromes, we're thinking about fibromyalgia. Referred pain is that originates from the visceral organ, and it may be felt in body regions remote from the site of pathology. One of the ones I think about is gallbladder. You actually can have posterior shoulder pain, and that would be an example of a referred pain. So nociceptive pain, we've already talked about. That's that activation of those nociceptors, and that is that chemical, mechanical, thermal noxious stimuli. Pain is usually clinically proportional to the degree of activation. This can be further delineated into acute or chronic. Chronic or persistent pain is lasting more than 3 to 6 months. Empathetically mediated pain is usually accompanied by evidence of it. So edema, changes in skin blood flow, abnormal motor activity in the region of the pain, the allodynia, hyperalgesia, or hyperpathia. Deafferation pain, chronic, and this results from a loss of the afferent input to the CNS. This may also arise in the periphery due to a nerve avulsion or spinal cord lesions, multiple sclerosis. Neuralgia pain or neuropathic pain lancinating, nerve damage, irritation along that distribution. This is usually what diabetics or cancer patients with chemotherapy get. It's initiated or caused by the primary lesion in the nervous system and leads to long-term changes of that pathway, called neuroplasticity. Often described as burning, shooting, shock-like, tingling, and is characterized by increasing sensitivity to stimuli. There can be, with neuropathic, there can be central or peripheral. An example of central neuropathic pain would be phantom pain or complex regional pain syndrome. Radicular pain, so this is usually from the nociceptor afferent fibers in the spinal nerve. Think sciatica, can have radicular pain in your arm as well from a lesion or a issue with the nerve root anywhere pretty much in the spinal root. And then psychogenic pain is inconsistent with the anatomic distribution. There's no apparent organic pathology despite the evaluation. Of note, for pain in children, you must be aware that they are quite different in responding to pain or allowing you to understand what the pain is. There are classic ways that we do it. Cries was one of them, but it's really a subjective of who is bringing them in as to what's going on with them. But due to their limited cognitive and language skills, you really cannot say that they're acting appropriately for what may be going on with them. Once they're above 3 to 4 years old, pretty self-reliable, but again, they are children, toddlers, so they may underreport because they do not want to get a shot because that's the only time that they see doctors. Now, on the opposite spectrum, pain in the elderly, they also too may underreport, or they do not want to complain. They may mask new situations and because there's a fear of, they're going to get placed in a home or things like that. So we have a couple different theories of pain. So we have specificity theory, pattern theory, gait control, and neuromatrix. Specificity theory is described by Descartes in the 17th century. And he proposed that there were specific pain receptors in the body that project to the brain, and then the intensity of the pain is directly related to the amount of associated tissue injury. So this was useful if you had a specific injury and the acute pain, but does not obviously talk about chronic or neuropathic pain or things that you cannot see. So this was pretty much discounted once we started getting into chronic cognitive emotional elements that related to pain theory. Pattern theory, that was late 19th century, and that was impulse intensity and repatterning of the central nervous system. This did kind of explain neuropathic pain, but it didn't account for many other pain theories. So he kind of built on that specificity and added the chronic pain, neuropathic pain kind of. The best one of to date, this is the one that I learned most about, and this is where multimodal pain control comes in, is the gait control theory. So with the gait control theory, it had non-nociceptive, which is the neuropathic, the central pain, and that could close the gait, and the nociceptive pain fibers would open the gait and increase the perception of the pain. And so the newest kid on the block is the neuromatrix theory, and this was proposed in 1999 because they were observing paraplegics and that did not fit into the theory. So what the neuromatrix theory does is that the brain produces patterns of nerve impulses that are drawn from those various endpoints, including genetics, psychologic, and cognitive. This is what we think about with phantom limb pain. So even though that limb is gone, it has been removed, the pain still is interpreted as being present. So once that stimuli has been removed, if you look at all the other theories, that does not make sense. But the neuromatrix accounts for that, and that is probably the closest one. So the neuromatrix builds on the gait control theory, but then adds the fact that there are these, it's burned into the memory of the brain that that pain is there. Multimodal pain therapy is supposed to help this prior to surgeries. So that is what's illustrating basically the plasticity of the brain. And as you can see here are the gates, and basically activating the non-nociceptor will close the gate to the nociceptor. So you have your large and small fiber impulses. It goes into the spinal cord dorsal horn, inhibitory interneuron. Excitation of it will block the pain and closes the pain gate. Inhibition of that will promote the pain and opens the pain gate. So chronic pain syndromes. Low back pain is actually the number one, but next to that is this myofascial pain syndrome, and that involves the injury to the muscles and the fascia. Muscle spasm, tenderness, stiffness. Musculoskeletal is obviously mechanical. We have neuropathic, we talked about that already. Fibromyalgia is more of a central pain syndrome. Chronic headache, 1 in 3 patients over the age of 65 are affected. At one of the bigger pain syndromes that you are going to come across. So this is fibromyalgia, and the overall prevalence of fibromyalgia is increasing, and according to the American College of Rheumatology, roughly about 2%. It is definitely higher in women. So as you can see here down with our prevalence and male to female ratio, female is greater than male, and it's basically 9 out of 10 females. 9 out of 10 patients, are female that have fibromyalgia. So what is fibromyalgia? So this is a chronic pain disorder, and it used to be classified by these trigger points. And this was one of the ways that we actually diagnosed it if you had a certain number. This has been removed from the criteria. And basically now what we look at is the fact that there is a history of chronic pain for more than 3 months, that there's also mood issues, sleep issues, cognitive issues. So when we classify primary fibromyalgia, it is basically whether they cannot find any other cause for the pain. Co-aggregate disorders would include irritable bowel syndrome, TMJ, interstitial cystitis, tension headaches, and vulvodynia. As you can see, there is a consistency there that all of these are really centralized, and really we don't know exactly why a lot of these happen. So irritable bowel syndrome, we know has a lot to do with serotonin in the gut and stress related. Interstitial cystitis is another one that is a pain syndrome. Really don't know why it happens, but it involves the bladder. And then tension headaches. So you can see here there's a cluster of things that are really together that help with the diagnosis of fibromyalgia. So the pathophysiology of this is that there is a central nervous system issue, and it involves pain and sensory amplification. The fact that individuals display a diffuse hyperalgesia, which is an increased pain response to normal painful stimuli, or they can have allodynia, which is pain in response to something that is not painful stimuli. Either one or a combination of both of those. So this suggests that there is really an issue with an augmented pain and sensory processing pathway, and it's in the central nervous system rather than some abnormality that is confined to an outside region, such as in the periphery. And that is the hallmark of these central pain syndromes. It does work on a lot of the pain pathway involving substance P, neurotransmitters glutamate, as well as serotonin, norepinephrine. So really involving all of those pathways that we just talked about. Clinical presentation, again, chronic pain for more than 3 months. Lots of tenderness on examination, muscle stiffness they'll wake up with, sleep disturbances, mood disturbances, cognitive issues. Also sensitivity to sensory issues, noise stimuli, odor stimuli, or light, and then overwhelming fatigue that is unrelieved by rest. All right, next up is temperature regulation. So hypothalamus is the control center for thermoregulation. It's achieved through the precise balancing of heat production, conservation, and loss. Maintain range around 37 degrees Celsius, 98.6 Fahrenheit. Normal range is considered to be 36.2 to 37.7. Some people run low, some people run high. Rarely do we get 41 degrees Celsius, but it does happen. Extremities are generally cooler than the trunk, and temperature at the core of the body is generally 0.5 degrees Celsius higher than surface. Their internal fluctuations related to circadian rhythm, as well as menstrual cycle. Gender has variance as well, lower during sleep as our whole body slows down. Temperature regulation is called thermoregulation. and it's by the hypothalamus mainly. We do have peripheral thermoreceptors in the skin, thermoreceptors in the hypothalamus, spinal cord, abdominal organs, and other central locations. Talking about body temperature rises, those blood vessels dilate, we have that heat loss to the environment, sweat glands secrete fluid, that a fluid helps evaporate and keep the body cool. Vice versa, if we are on the cold side, then we have constriction of the blood vessels, heat is conserved, sweat glands do not secrete, and then we have shivering and makes the body move and creates that heat. So children are different as well as elderly. For a child, they have greater surface area, they have slower sweat rates, they do have more brown fat. Sweating is also initiated at a higher temp set point, and it's more dilute. There's also slower acclimation to the hot environments, and then they have a decreased thirst response. Concerning infants, especially low birth weight, premature, they require special attention because of the body temperature issues. Normal term infants have that brown fat. Once they're older, though, they have little subcutaneous fat, and then they're not nearly as well insulated as adults. For our dissipation mechanisms, we have evaporation, conduction, convection, radiation. So you can see there, sweat evaporation, which is our primary mechanism, go about 600 kcals an hour. We have about a maximum of 3 liters an hour, and then it becomes much less effective if you're in a humid environment. Conduction, that's why we apply cold packs, and then cold water immersion is a very expedient way to dissipate heat. Convection, that is the fans that we use. That cooler air blowing across it can also dissipate with great. This is why we also want permeable clothing. Infrared dissipation, radiation, basically, we are reflecting the light away. Fever. Mechanisms of fever is not a failure of normal thermoregulatory mechanism. Fever is actually protective, and it is considered a resetting of the hypothalamic thermostat to a higher level. So it's not a failure, it's actually resetting it. So normal thermoregulatory mechanisms are raised so that the thermoregulatory center adjusts the heat production, conservation, and loss to maintain that core temperature at the new higher set temperature. So during that fever, we have vasopressin release, melanocyte stimulating hormones, corticotropin releasing hormones, and they actually act as endogenous antipyretics to help diminish that febrile response. So due to that antipyretic effect, the fever breaks, and then that return to set point is basically what happens. So remember how we been saying the whole way through this course is we have an on switch, we always have an off switch. We have actually antipyretics within our body, and that is what basically brings the fever back down. So what are the benefits of the fever? We are trying to kill microorganisms. Also, it decreases serum levels of iron, zinc, and copper, which we learned are very important for bacteria to replicate. Lysosomal breakdown and autodestruction of cells with increased temperature, so that prevents viral replication and infecting the cells. It also increases lymphocytic transformation and motility of PMNs, facilitating more of an immune response. And then also phagocytosis is enhanced. So that is why it's protective. It's basically the body's job of trying to get rid of that microorganism. So we do have some dysregulation of this mechanism consistent with greater than 38 degrees Celsius or greater than 100.4 Fahrenheit. It's usually very important to have a fever with a focus. What we don't like are fever of unknown origins. FUOs, infectious diseases, malignancies, autoimmune, and other. But you got to investigate everything. And child, it's usually related to rare diseases, but could also, remember we talk about the zebra, it could actually be a horse presenting unusually or atypically. Always thinking fever, chills, weight loss, night sweats, malaise, and pain. And anytime we have a fever unknown origin, we're always investigating etiology and have they gone anywhere. Malignant hyperthermia. So this is related to a rapid rise in the body temperature. There's muscle rigidity, hypertension, and tachypnea. It's related to a RI1 defect, and that releases calcium in the muscle. And then we have oxidative metabolism within that. So it's potentially lethal. Usually have to have a volatile anesthetic or a neuromuscular blocking agent administered. The risk of it is 1 in 200. And what happens is that because of that release of calcium, we have uncoordinated muscle contractions, sustained muscle contractions. That will then create a temperature rise of 1 degree Celsius or 1.8 degrees Fahrenheit every 5 minutes. So you can obviously see how this can get out of control very quickly. Heat stroke, potentially lethal consequences, basically breakdown in overstressed thermoregulatory center. It cannot tolerate the temperatures of more than 40.5. Very high core temperatures, regulatory center ceases to function appropriately, sweating ceases, skin becomes dry, flushed, patient may be very irritable, confused, stuporous, or comatose. Evaporation of perspiration ceases, the core temperatures will then rise because we lose that convection. Children are more susceptible to heat stroke than adults are. Be aware of that, related to their higher surface mass, surface area to mass, and their difference in perspiring. Hypothermia slows chemical reactions. You can see the levels there, core temp less than 95 or 35 degrees Celsius. What happens then is we have slowed chemical reactions, increased blood viscosity, less blood flow then because of that increased viscosity. Then we also have coagulation factors, and then profound vasoconstriction. The young and elderly are most at risk because they have less effective thermoregulatory mechanisms. And then also anybody that has a diminished ability to generate heat, such as hypothyroidism, hypopituitary, Parkinson's, RA, because of being unable to create that reaction. Depending on the severity, rewarming of the peripheral tissues may be the only treatment required. If you drown in cold water, it's much better than drowning in hot water. And if you are going to rewarm, then we have to actually do it slowly, no faster than a few degrees per hour. Next up is sleep. So active brain process that provides restorative function and promotes memory consolidation. There is a special area within the hypothalamus that controls the timing of the sleep-wake cycle, suprachiasmatic nucleus. We have the cycle called the circadian rhythm. It's a 24-hour rhythm cycle, and normal sleep has 2 phases that can be described and documented on the EEG, which is rapid eye movement sleep, and non-rapid eye movement sleep. They then further divide the non-REM into a couple different stages. So we have wakefulness with eyes closed. That's when we have alpha waves, awake alpha waves. Non-REM sleep stage 1, sleep onset. We're drowsy, lower threshold for arousal at this time. This stage actually increases with age. We have more brief awakenings, and that's what accounts for fragmented sleep. NREM2 is light sleep with sleep spindles seen on the EEG. Non-REM3 is non-REM sleep stage 3. This is when delta waves start. There is literally no eye movement, and then we get into REM sleep. So REM stands for rapid eye movement. This is the most restorative, the deepest. This is when a lot of our repair. So when we talk about what it looks like now, this is kind of the pattern we see. So we'll have stage 1, stage 2, stage 3, and then we have a variance coming back in, and then we get REM. And as you can see, then we don't get these deeper stages later on. We just go between the first 2 stages and go back into REM. So there are some of the things that happen with non-REM and then REM. You can see over here, we have provocation of medical symptoms, CAD, COPD, PUD, GERD, migraine, and cluster headaches related to the REM. Dysomnia, so we have a couple here. We have insomnia, obstructive sleep apnea, obesity, hypoventilation syndrome, restless leg, hypersomnia, narcolepsy, and circadian rhythm disturbances. The insomnia, inability to fall or stay asleep, may be transient or related to time zone issues or acute stress. Long-term is usually related to drug or alcohol abuse, chronic pain, or chronic depression. Obstructive sleep apnea is disorder related to upper airway obstruction associated with reduced oxygen saturation and hypercapnia. That is related to obesity, male gender, and age. Very scary stuff. Loud snoring, gasping, intervals of apnea. There's usually an obstruction. It's caused by the soft palate, base of the tongue. Then you have collapsing of the pharyngeal walls, decreased muscle tone during that REM sleep. Hypersomnia is excessive daytime sleepiness. It's associated with obstructive sleep apnea because of their difficulty sleeping, so then they will sleep during the day. And this is difficult because it may be while they're driving a car or working or talking. Multiple causes. There's also unknown causes. It all depends if you're going more idiopathic versus central versus medication. Idiopathic hypersomnia is actually pretty rare. It's 20 to 50 per million. And then when you talk more about secondary to OSA or medications, alcoholism, then you're talking basically about a secondary hypersomnia. Obesity, hypoventilation syndrome, overweight, it's pressing on the diaphragm, and then we have decreased ventilation related to that. Restless leg syndrome is sensory motor disorder. There's a prickling, tingling, crawling sensation. It gets worse in the evening and at night to the point where they can't sleep related to it. And then we have narcolepsy, which is primary hypersomnia of central origin. Daytime sleep, also characterized by hallucinations, sleep paralysis, or cataplexy. And cataplexy is brief spells of muscle weakness or paralysis. They may think that this basically is related to maybe the hypocretin system deficiency and immune mediated. There may be a genetic component as well. Circadian rhythm sleep disorders, that is working night shift, jet lag. We are altering the time that we're supposed to be sleeping, and then that will make us have varying degrees of issues with trying to sleep then. This is something that you'll see a lot of. People don't sleep. What you need to do are sleep diaries, and then you can do further testing or watch them sleep. But 100 billion each year is lost due to unmanaged insomnias. Sensory, so now we're going to get into the sensory organs. So vision, hearing, olfaction. All right, so taste, we have hypergeusia, ageusia, or parageusia. Touch, impairment, can alter reception, transmission, perception. Can all alter that tactile sensation. And proprioception is your awareness of yourself in the world. Things that can alter that are vertigo, Meniere's, and then peripheral neuropathies. The external eye, what we're looking at, blepharitis, hordeolum, chalazion, conjunctivitis, or keratitis. Keratitis are going to be your pathologies. The wall of the eye consists of 3 layers: sclera, choroid, and then retina. Retina is the innermost layer of the eye, contains millions of rods and cones, and those are special photoreceptors that convert light energy into nerve pulses. Your rods mediate peripheral and dim light vision. Cones are dense and they are related to color and detail. Choroid is the deeply pigmented area. Middle layer that prevents light from scattering inside the eye. The iris is part of it, as well as the pupil where the light passes. And then there's also some smooth muscle fibers that control the size of the pupil to allow that light to come. Have vitreous humor, which is the gel-like substance that fills the vitreous chamber. You have aqueous humor, which fills the aqueous chamber. That helps maintain that pressure inside the eye. You can see the anterior chamber up here, and we have liquid there, and then we have the vitreous humor in this portion. We have normal eye, bacterial versus allergic versus viral. There are the descriptions. So you see blepharitis here, which is inflammation of the eyelids, and that's caused by a staph or seborrheic dermatitis. Very itchy, redness, and some edema. Conjunctivitis, you all probably understand pretty well, and that is an inflammation of the conjunctivae, and that is bacterial, viral, or chemical, or allergic. Chalazion over here, and a hordeolum. We used to call the hordeolum styes. and that's pretty much why they're quite painful as well. One is the bigger gland that's in this with the chalazion, or with the hordeolum. It's a smaller gland that's more close to the eyelid. Results in reduced vision in the affected eye because there is cerebral blockage of the visual stimuli. The deviation over here is called entropia, or extropia if it's downward or inward. So strabismus is one eye deviates from the other when the person is looking at an object. This is caused by weak or hypertonic muscles in one eye. Nystagmus is involuntary or unilateral or bilateral rhythmic movement of the eyes. It's usually present at rest or if the eye moves. You have pendular nystagmus as well as jerk nystagmus. Jerk nystagmus is one phase of the eye movement is faster than the other, and that can be an imbalance. Cataracts, incidence increases with age. We also have increased risk with certain pathophysiological issues. Basically, you see this normal lens here. With a cataract, you have a cloudy lens. Most common form of cataract is degenerative, but they also may recur because of infection, trauma, or diabetes. They cause decreased visual acuity, blurred vision, glare, and decreased color perception. Glaucoma, second leading cause of blindness. We have increased intraocular pressure. There are a couple types: primary open angle or acute angle closure. Acute angle closure is a medical emergency. Primary open angle is more on the chronic. So open angle is basically a type of glaucoma and the outflow obstruction of aqueous humor at the trabecular meshwork or canal of Schlemm. So when we're talking about the aqueous humor, so we're talking about in here is where we usually have the issue. With angle closure, the type of glaucoma, acute angle glaucoma, is more of emergency because it literally is stopped and the outflow of the aqueous humor, and that causes sudden rise in the IOP. Macular degeneration, leading cause of adult blindness, classically presents white people age 55, sudden onset blurring or distortion of vision. You can have atrophic, which is dry, non-exudative, and neovascular, which is wet or exudative. Drusen is waste products from the photoreceptors. This is an accumulation factor. So we get the waste products and it accumulates, called drusen. Hypertension, cigarette smoking, diabetes, family history are all risk factors for age-related macular degeneration. Hearing. So the ear is divided into three basic areas: external, only involved in hearing; middle ear, involved only with hearing; and then the inner ear, which is involved with hearing and equilibrium. Your middle ear has the tympanic cavity, which is a small chamber in the temporal bone, and it has three ossicles known as the malleus, incus, and stapes. A Eustachian tube. The cochlea has the organ of Corti. Ear infection, so this is otitis externa. This is going to be outer ear or swimmer's ear, usually Pseudomonas or staph. This is pretty painful, and usually there's some nasty discharge or redness. There's an oral fullness and some hearing loss related to it. It's very common. Can be acute or chronic, infectious or non-infectious. E. coli is also involved there. Fungal infection, less common. It also can be prolonged exposure to moisture, which is swimmer's ear, itching, swelling, clear drainage that progresses to purulent. You can then have otitis media, which is common, especially in small children, and that's usually strep or influenza or Moraxella. And you can have some predisposing issues with allergies. Olfaction and taste. Olfaction is related to cranial nerve 1. Taste, also known as gustation, is multiple nerves in the tongue, soft palate, uvula, pharynx, and upper esophagus. So there is a strong relationship between smell and taste, and that creates the sensation of flavor. There are about 7 different primary classes of stimulants that we've identified so that we smell and can identify, I guess, or classify. Camphoraceous, musky, floral, peppermint, ethereal, pungent, and putrid. And then the primary sensations of taste are sour, salty, sweet, bitter, and savory. So unfortunately, this decreases with age. Remember, those older people tell us nothing tastes good anymore. It's usually because we lose our olfaction and taste receptors. Also, some things that happen with aging and our loss of olfaction and taste is usually around 80 we decline in the sensitivity to odors, which may lead to diminished appetite and may alter nutrition. They also have an inability to smell toxic fumes or gases, and that poses a safety hazard. So there are some definitions. Hyperosmia is impaired smell. Anosmia is no smell. Complete loss of smell. Parasomnia is a perverted or abnormal sense of response to that smell. Taste can be altered by injury or impairment to the hippocampus. When we're talking about touch, we have 4 afferent fiber types that mediate tactile sensation. This develops before birth and continues into early adulthood. That will gradually decline after that as we lose the ability to sensitize our tactile function. Anything that interrupts or impairs reception, transmission, perception will then alter and give you tactile dysfunction. Proprioception depends on impulses from the inner ear and receptors of joints and ligaments. Progressive loss of proprioception has been reported in elderly. You can have some issues with spinocerebral tracts, the dorsal columns, vestibular dysfunction, or neuropathy. This would be vertigo. This is sensation of spinning that occurs, and that is usually the room spinning around. Peripheral neuropathies cause proprioceptive dysfunction. Renal disease, diabetes would be where you're leading towards that, and that's basically diminished or absent sense of the position or body parts. Think about their feet. They'll often have gait changes. Meniere's disease is a vestibular disorder that causes proprioceptive dysfunction. Don't really know what causes it or the pathological basis. If they get it, may be unable to stand or walk. All right, that's it.